Coronary artery disease and stable angina Merrill chronic, DO, FACC, FACP, FSCA Blake D. Singletary, DO Basics Description Coronary artery disease, CAD, refers to the atherosclerotic narrowing of the epicardial coronary arteries. It may manifest insidiously as angina pectoris or as an acute coronary syndrome, ACS. Stable angina is a chest discomfort due to myocardial ischemia that is predictably reproducible at a certain level of exertion or emotional stress. The spectrum of ACS includes unstable angina, UA, non-ST elevation myocardial infarction, NSTEMI, and ST elevation myocardial infarction, STEMI. See chapters on ACS for further information. Definitions. Typical angina exhibits three classical characteristics: I. Substernal chest pressure, or heaviness that may radiate to the jaw, back, or arms and generally lasts from 2 to 15 minutes. 2. Occurs at a certain level of myocardial oxygen demand from exertion, emotional stress, or increased sympathetic tone. And 3. Relieved with rest or sublingual nitroglycerin. Atypical angina exhibits two of the above typical characteristics. Non-cardiac chest pain exhibits less than or equal to one of the above typical characteristics. Anginal equivalent patients may present without chest discomfort but with nonspecific symptoms such as dyspnea, diaphoresis, fatigue, belching, nausea, lightheadedness, or indigestion that occur with exertion or stress. Patients with diabetes mellitus, women, and the elderly may present with more atypical features as compared to the general population. UA. Anginal symptoms that are new or more frequent, more severe, or occurring with lessening degrees of myocardial demand. It is considered ACS but does not present with cardiac biomarker elevation. See acute coronary syndromes, NSTEACS, unstable angina and NSTEMI, chapter. NSTEMI, elevation of cardiac biomarker, troponin, with either anginal symptoms, ischemic ECG changes other than ST elevation, or both. See acute coronary syndromes, NSTEACS, unstable angina and NSTEMI, chapter. STEMI, presents with typical symptoms as mentioned above with ST elevations noted on ECG, generally caused by acute plaque rupture and complete obstruction of culprit vessel and may present prior to laboratory detection of troponin. See acute coronary syndromes, STEMI chapter. Canadian Cardiovascular Society Grading Scale, Class I, angina does not limit ordinary physical activity, occurring only with strenuous or prolonged exertion, 7 to 8 metabolic equivalents METs. Class II, angina causes slight limitation of ordinary activity. It occurs when walking rapidly, uphill, or greater than 2 blocks, climbing greater than 1 flight of stairs, or with emotional stress, 5 to 6 METs. Class III, angina causes marked limitation of ordinary physical activity. It occurs when walking 1 to 2 blocks or climbing 1 flight of stairs, 3 to 4 METs. Class IV, angina occurs with any physical activity and may occur at rest, 1 to 2 METs. Geriatric considerations. The elderly may present with atypical symptoms. Physical limitations may delay recognition of angina until it occurs with minimal exertion or at rest. Maintain a high degree of suspicion during evaluation of dyspnea and other nonspecific complaints. Geriatric patients may be very sensitive to the side effects of medications used to treat angina. Epidemiology. CAD is the leading cause of death for adults both in the United States and worldwide. CAD is responsible for about 1 in every 3 deaths in the United States alone. The cost of CAD in the United States was $555 billion in 2016 and is expected to rise to $1.1 trillion by 2035. 80% of CAD is preventable with a healthy lifestyle. Incidence in the United States. The lifetime risk of a 40-year-old developing CAD is 49% for men and 32% for women. Prevalence in the United States. 28.4 million people carry a diagnosis of CAD, whereas 7.12 million have angina pectoris. Etiology and pathophysiology. Anginal symptoms occur during times of myocardial ischemia caused by a mismatch between coronary perfusion and myocardial oxygen demand. Atherosclerotic narrowing of the coronary arteries is the most common etiology of angina, but it may also occur in those with significant aortic stenosis, pulmonary hypertension, hypertrophic cardiomyopathy, coronary spasm, or volume overload. Sensory nerves from the heart enter the spinal cord at level C7-T4, causing diffuse referred pain/discomfort in the associated dermatomes. Risk factors. Traditional risk factors: hypertension, high-density lipoprotein, low-density lipoprotein, LDL, smoking, diabetes, premature CAD in first-degree relatives, men 55 years old, women 65 years old, age, greater than 45 years for men, greater than 55 years for women. Non-traditional risk factors: obesity, sedentary lifestyle, chronic inflammation, abnormal ankle brachial indices, renal disease. General prevention: smoking cessation, regular aerobic exercise program, weight loss for obese patients, goal body mass index, BMI, 25 kg/m2, blood pressure, BP, control, goal 140/90 mmHg, consider 130/80 mmHg for those with 10-year risk greater than or equal to 10%. 1. C. Diabetes management: statin therapy for those with diabetes age 40 to 75 years and those with 10-year risk greater than or equal to 7.5–10%. Recommendations of advisory organizations vary, and the American College of Cardiology/American Heart Association risk calculator overestimates risk in many. Low-dose aspirin should no longer be recommended for routine primary prevention of myocardial infarction, MI, without objective evidence of CAD. Benefits and harms are closely balanced, with no strong evidence for reduction in all-cause mortality, but with evidence for a reduction in cardiovascular events at the cost of increased major GI bleeding. 2. A shared decision-making approach may consider aspirin for primary prevention in patients aged 50–69 at highest risk of coronary artery disease and at low risk of GI bleeding. 2. It may be used for those with high clinical suspicion in the interim prior to stress testing/catheterization. Commonly associated conditions: hyperlipidemia, peripheral vascular disease, cerebrovascular disease, hypertension, obesity, diabetes. Diagnosis: history. Careful history is important to elicit symptoms. Pain may be described with a clenched fist over the center of the chest, Levine sign. Discomfort is usually not affected by position or deep inspiration. Episodes of angina are generally of the same character and in the same location as previous episodes. Recent decrease in level of physical activity may be due to worsening anginal symptoms. Dyspnea on exertion may present as the only symptom. Atypical symptoms are more likely in women, the elderly, and diabetic patients. May present with symptoms similar to gastric reflux or GI upset, indigestion, nausea, diaphoresis. Physical exam. Normal cardiac exam does not exclude the diagnosis of angina or CAD. Cardiac exam may reveal dysrhythmias, heart murmurs indicative of valvular disease, gallops, or signs of congestive heart failure. Evidence of peripheral vascular disease, diminished pulses, Brutes, abdominal aortic aneurysm AAA, may or may not be noted. Differential diagnosis: vascular, aortic dissection, pericarditis, myocarditis, MI, vasospasm. Pulmonary, pleuritis, pulmonary embolism, pneumothorax. Gastroesophageal, gastric reflux, esophageal spasm, peptic ulcer. Musculoskeletal, costochondritis, arthritis, muscle strain, rib fracture. Other, anxiety, psychosomatic, cocaine abuse. Diagnostic tests and interpretation: initial tests, lab, imaging, serial cardiac troponins for those presenting acutely with symptoms. Complete blood count, lipid profile, HbA1c for risk stratification, basic metabolic panel to rule out electrolyte abnormalities and assess renal function. ECG should be obtained unless there is a non-cardiac cause of the chest pain, frequently unremarkable between anginal episodes. May show signs of myocardial ischemia during symptomatic episodes. Evidence of old MI, left bundle branch block or ventricular pacing makes interpretation for ischemia unreliable. Chest X-ray may exclude other causes of pain. Follow-up tests and special considerations. Goal is to detect high-risk coronary lesions where intervention would improve long-term mortality or alleviate anginal symptoms. Stress testing is most helpful for patients at intermediate risk of CAD. Exercise testing for those who can physically exercise, greater than or equal to 5 METs. Standard exercise ECG for those with normal baseline ECG, i.e., without left bundle branch block or ventricular pacing. Exercise stress testing with echo or perfusion imaging for those with abnormal baseline ECG or in premenopausal women. In patients who cannot tolerate exercise, consider pharmacologic stress testing. Echocardiogram should be obtained in patients with a new or loud, greater than or equal to 3/6, murmur, evidence of MI, symptoms of heart failure, concern for hypertrophic cardiomyopathy or pericardial effusion, and in those with new arrhythmias. A normal echocardiogram does not rule out CAD. Echocardiogram can be considered in patients with hypertension or diabetes and abnormal ECG. CT coronary angiography or cardiac MRI can be considered as a supplement/alternative to stress testing in patients with continued symptoms despite negative stress testing, inconclusive stress testing, or need for better anatomic definition of disease. Diagnostic procedures/other cardiac catheterization with coronary angiography is the gold standard for confirmation and delineation of coronary disease and direction of interventional therapy or surgery. It is indicated if non-invasive testing suggests a high-risk lesion or if patient fails to respond to appropriate medical management. Significant CAD is defined as greater than or equal to 50% stenosis of the left main coronary artery or greater than or equal to 70% stenosis of other major coronary arteries by angiography. Borderline lesions may be assessed with a pressure wire. Fractional flow reserve, FFR, of less than or equal to 0.8 demonstrates a hemodynamically significant lesion. Treatment general measures BP control goal for most patients with significant CAD, 130/80 mmHg, 1, Smoking cessation goal, complete cessation, no exposure to second-hand smoke or e-cigarettes. Physical activity goal, 30 to 60 minutes of moderate aerobic activity, at least 5, preferably 7, days/week. Weight management goal, BMI 18.5 to 24.9 kg/m2, waist circumference 35 inches, women, or 40 inches, men. Individualized glycemic control goals in diabetics, avoid hypoglycemic episodes. Medication: first-line beta blockers, decrease myocardial oxygen demand by lowering heart rate, BP, and contractility, improve mortality in patients with MI or heart failure and should be used as initial therapy. Can improve symptoms of angina. Metoprolol, 25 to 400 mg daily succinate or divided bid tartrate, or carvedilol, 3.125 to 25 mg bid. Adjust doses according to clinical response. Maintain resting heart rate 50 to 60 bpm. Side effects: bradycardia, fatigue, and sexual dysfunction predominantly in men. Calcium channel blockers, CCBs, cause arterial vasodilation, decreased myocardial oxygen demand, and improved coronary blood flow. Similar effectiveness to beta blockers, may be used instead of or in addition to beta blockers. Only long-acting CCBs should be used. Dihydropyridine CCBs, nifedipine, 30 to 90 mg/day, amlodipine, 5 to 10 mg/day, or felodipine, 2.5 to 10 mg/day, work predominantly on arterial vasodilation and can improve coronary blood flow. Non-dihydropyridine CCBs, diltiazem, 120 to 480 mg/day, or verapamil, 120 to 480 mg/day, also have negative inotropic effects and should not be used in those with ejection fraction 40% because they may precipitate heart failure. Side effects include constipation and peripheral edema. Nitrates dilate systemic veins and arteries, including coronary vessels, and cause decreased preload. At higher doses, they decrease BP sublingual nitroglycerin, 0.4 mg every 5 minutes for up to 3 doses, used for acute anginal episodes. Long-acting nitrates such as isosorbide mononitrate, 30 to 240 mg daily extended release, can be used for angina prophylaxis. Side effects include headache and hypotension but tend to improve with continued usage. Contraindicated with concomitant phosphodiesterase type 5 inhibitor use, e.g., sildenafil, lipid-lowering agents. High-intensity statin therapy is indicated for all patients with CAD regardless of lipid levels. Statin therapy should also be strongly considered for those with high CAD risk, lifetime ischemic risk greater than or equal to 7.5–10%, 75 to 80 years. Evidence for benefit is sparse for statins in primary prevention after 75 years. Atorvastatin, 40 to 80 mg/day, and rosuvastatin, 20 to 40 mg/day, are high-intensity statins. Statins reduce risk of MI and revascularization need. Side effects include myalgias, transaminitis, rhabdomyolysis, rare, and impaired glucose tolerance. Ezetimibe may be added to statin therapy if LDL is not at goal after maximally tolerated dose of statin, especially in secondary prevention. Proprotein convertase subtilisin/kexin type 9 inhibitors further reduce LDL levels when used in combination with statins for high-risk patients and reduce cardiovascular events in highly selected patients but are very expensive. Antiplatelets decrease risk of thrombosis. Aspirin, 75 to 162 mg/day, decreases risk of first MI and reduces adverse cardiovascular events in those with stable angina. Clopidogrel, 75 mg/day, may be used in patients with contraindications to aspirin. Dual antiplatelet therapy with aspirin and clopidogrel, prasugrel, or ticagrelor is indicated after MI or percutaneous coronary intervention, PCI. Use prasugrel only after PCI. Do not use in patient with CVA history. Angiotensin-converting enzyme inhibitors, ACEIs, act on the renin-angiotensin-aldosterone system to reduce BP and afterload. They also have effects on cardiac remodeling after MI. ACEIs such as lisinopril, 5 to 40 mg/day, and enalapril, 2.5 to 20.0 mg bid, have been shown to reduce both cardiovascular death and MI in patients with CAD and left ventricular systolic dysfunction. Angiotensin receptor blockers such as candesartan, 4 to 32 mg daily, may be used in patients intolerant to ACEIs. Side effects include cough, ACEIs predominantly, hyperkalemia, and angioedema. Second-line ranolazine, 500 to 1000 mg bid, decreases calcium overload in myocytes, acting as an anti-anginal/anti-ischemic agent. Does not affect heart rate or BP. Use as adjunctive therapy when symptoms persist despite optimal doses of other anti-anginals. Side effects can include nausea, constipation, dizziness, QT prolongation, and headache. Surgery/other procedures. Revascularization should be considered if optimal medical therapy is inadequate to control symptoms. PCI with balloon angioplasty and/or stent placement, with drug-eluting or bare metal stent, is performed for significant lesions. Additional techniques include laser therapy and atherectomy. Current literature does not show that PCI decreases mortality or risk of MI versus aggressive medical management in those with stable angina. Coronary artery bypass graft, CABG, is preferred over PCI for those with severe left main coronary stenosis, significant lesions in greater than or equal to 3 major coronary arteries, and for lesions not amenable to PCI. Complementary and alternative medicine relaxation/stress reduction therapy for angina. Ongoing care follow-up recommendations. Lifestyle modifications should be aggressively stressed at every visit. Patient monitoring. Frequent follow-up after initial event, every 4 to 6 months in first year and then 1 to 2 times per year. Diet. Reduced intake of trans fatty acids. Adherence to dietary modification for comorbid conditions, diabetes, heart failure, hypertension. Prognosis variable, depends on severity of symptoms, extent of CAD, and left ventricular function complications. ACS, arrhythmia, cardiac arrest, heart failure. Reference